Welcome to this video on pharmacotherapy. This video and the next set of videos are very important. If you ask me the difference between MBBS graduate treating diabetes and a super specialist treating diabetes, first I would say is evidence-based medicine. If you see super specialists, they are very thorough with Indian and international guidelines. Second is reasoning. If you add metformin or if you don't add glimepiride, you should always have reason why did you add a specific tablet in a patient and why did you omit certain tablet in a patient. Reasoning. And third is the personalized medicine. You should always be able to treat the patient according to the needs and according to the paying ability of the patient. You should understand how much the patient can pay. Accordingly, you will have to balance between the quality and the cost of the treatment. These three are very important quality if you want to be a best diabetologist. And in this and the coming series of video, I'll be teaching you the protocols and about individual pharmacology of each class of drugs. When you start treatment of a diabetes, there are four important things. I would say it has four important pillars. The first one is you should always educate the patient about diet and exercise. This has been very extensively covered in the previous section, educating patients for healthy lifestyle. The second is pharmacotherapy for type 2 diabetes, which will be covered in this and the subsequent videos. The third is treat associated conditions. I always tell my patient that diabetes, hypertension, dyslipidemia, these are like family members. If one person enters into your body, other members of the family also enter, right? So if the patient is diabetic, you should also screen for associated conditions like obesity, hypertension and dyslipidemia. The next important, very important thing, this is one of the important thing, right? The important difference between MBBS graduate treating diabetes and specialist treating diabetes to manage and screen for the complications. You should always screen the patient for retinopathy, nephropathy, ASCVD, neuropathy. This is the screenshot of my video, history taking and investigations in a patient with diabetes mellitus. Whenever you diagnose a patient with diabetes, there are certain basic investigations you should ask the patient to get it done. First is always complete blood count. Why is it important? One is chronic metformin therapy actually causes B12 deficiency. Okay. So to understand if the patient has developed B12 deficiency anemia, you will have to get metformin done. The second is iron deficiency anemia and vitamin B12 deficiency anemia can cause falsely increased HbA1c levels. Imagine the patient is anemia. The patient has hemoglobin of 10 and HbA1c is 6.7. In this case, you should always remember that anemia would have caused falsely elevated levels of HbA1c. Next, you should screen for associated. You get HbA1c done in the first visit. As and when the patient is diagnosed with diabetes, get HbA1c done. If the HbA1c is stable, then you can repeat it after 6 months. If the HbA1c level is fluctuating, like increasing, decreasing, then get it done every 3 months. Then screen for associated condition. Check for patient's BP and fasting lipid profile. Apart from that, you should also screen for the complications of diabetes. The important complication of diabetes is retinopathy, neuropathy and nephropathy. So you should counsel the patient to go to ophthalmologist and get retinopathy screening done. Then for neuropathy, you can check for sensation of fine touch, vibration, proprioception, reflexes in the patient. And for nephropathy, you will do spot urine by albumin, like we call it as ACR, spot urine albumin by creatinine ratio. If the patient is diabetes and hypertensive, and if the patient is on AC inhibitors or ERBs, you will get serum potassium done as well. Then looking for supplements like micronutrients. If the patient is affordable, you can get these serum B12 and calcium done. Okay, if the patient is not affordable, I won't get it done in those patients. Vitamin D, magnesium is very rare. Like clinically, I don't get it done in patients. Only when I feel the patient might be vitamin D deficient, or if the radiograph anything is showing osteopenia, or the patient has osteoporosis, only then I'll screen the patient. Otherwise, I won't screen because vitamin D is very costly. One of the important thing you have to remember is the best treatment is the one the patients can afford. Okay, especially in India, right? You might try to give the best treatment, but in turn you might increase the cost to the patient. Okay, in the second scenario you might try to balance the cost, and in turn you might decrease the quality of the patient, quality of the treatment to the patient. In Indian scenario, you'll have to always balance between the cost and the treatment. Okay, whenever you're treating, the first and foremost goal is to maintain the sugar levels. But now we have newer anti-diabetics which, apart from maintaining glucose levels, it can also take care of other things. What are they? Reducing the risk of ASCVD, atherosclerotic cardiovascular disease. Then reduce the risk of heart failure, reducing the risk of diabetic kidney disease, preventing weight gain. There might be a patient who is very obese, right? Some diabetic medications can increase the weight. So your goal will be to maintain the glucose levels and also ensure that the patient will not gain further weight due to anti-diabetic medications. Preventing hypoglycemia and managing treatment causes is very, very important when you're practicing in India. Once the patient is diagnosed with diabetes mellitus, if your goal is to reduce the risk of atherosclerotic cardiovascular disease, there are two classes of antidiabetics which can actually help you in reducing the risk of patient's ASCVD risk. In SGLT2 inhibitors, there are two drugs, which first is canagliflozin and second is empagliflozin. These two drugs in SGLT2 inhibitors can actually reduce the risk of ASCVD in patients. However, I'll tell you, each tablet costs around 50 to 60 rupees. It means that this alone will give them 1,500 to 2,000 rupees per month. So you will be able to prescribe the drugs only in very well off patients, otherwise you won't be able to. In GLP-1 receptor agonists, which are the drugs which can improve or reduce the risk of ASCVD? It is liraglutide, dulaglutide and semaglutide. Even these are costly. You won't be able to use it. You will be able to use it in only very well off patients. Then apart from this, which can actually help in reducing risk, that is thiazolidinediones. Okay, if you have to reduce, apart from, along with managing glucose levels, if you have to reduce the risk of ASCVD in patients, you can use three drugs: SGLT2 inhibitors, then GLP-1 agonists and thiazolidinediones. Now, if your goal is to reduce the risk of heart failure, imagine a patient is diabetes and he has hypertension for so many years. Then you can use SGLT2 inhibitors. They can reduce the risk of heart failure also. Here, all are known to reduce the risk: canagliflozin, dapagliflozin, empagliflozin and ertugliflozin. The affordable SGLT2 inhibitor is dapagliflozin. You can use it, but these are very rare because they are very, very costly. Third, if you want to reduce the progression of diabetic kidney disease, even then you can use two classes of drugs. These same drugs, SGLT2 inhibitors and GLP-1 receptor agonists. SGLT2 inhibitors, you can use these three: canagliflozin, dapagliflozin and empagliflozin. Ertugliflozin is not useful in preventing the progression to diabetic kidney disease. You can use these three. And GLP-1 analogs, same: liraglutide, dulaglutide and semaglutide. Okay, ASCVD, SGLT2 inhibitors, GLP-1 analogs, SGLT2 canagliflozin, empagliflozin, and GLP-1 liraglutide, dulaglutide, semaglutide. Apart from that, which other class of drug are can help in reducing the risk of ASCVD, thiazolidine dions. If you want to reduce the risk of heart failure, you can use any of the SGLT2 inhibitors. If you have to reduce the risk of progression to diabetic kidney disease, then same SGLT2 inhibitors and GLP-1 analogs. Dapagliflozin is the only affordable GLP-1 analog. SGLT2 inhibitors. Others are very, very costly. Now, if your goal is to balance the cost, I have arranged these medicines from cheapest to costliest. It's not exact, this is arbitrary, because even in one class of drug, one drug might be very costly, another drug might be very cheap. I would say if the patient is from the low income group, you try using these to manage diabetes. If the patient is from middle income group, you can try this. And only if the patient is very well off, you can use this GLP-1 analogs, new insulin and insulin pumps. Weight management. There are certain antidiabetics which cause weight loss, certain antidiabetics which cause weight gain, and certain which are very weight neutral. So weight loss which cause weight loss, SGLT2 inhibitors and GLP-1 analogs. Which are weight neutral, metformin and DPP-4 inhibitors. I say metformin, some references say it's weight neutral and some references say it causes modest weight loss, but I consider it as weight neutral. Weight gain is caused by insulin, sulfonylureas and thiazolidine diones. If your main goal is to prevent hypoglycemia, then there are only two drugs which cause one is the famous insulin, second is sulfonylureas. These two cause hypoglycemia, and if you are treating any patient who has episodes of hypoglycemia, or you feel that the patient is at risk of hypoglycemia, mainly very elderly patients, you should always use these medications very, very carefully. Let's come to interesting now. I told you, right, this has to be done, this use. Now how do you actually implement in practical scenarios? We'll actually practice with some case studies. A 45-year-old patient who is a daily wage laborer has type 2 diabetes mellitus. His BMI is 22. His fasting blood sugar is currently 200. There are no other comorbidities. Which class can be used? Let's see, the patient is middle-aged. He is a daily wage laborer. BMI is 22 is fine. And fasting blood sugar is 200. Then no other comorbidities. Which class of drugs can be used in this patient? Let's see. Do you want the patient to have less risk of ASCVD? I would say no, because the patient weight is fine, he has no comorbidities. My goal is not to reduce the risk of ASCVD. What about DKD? No. Heart failure? No. Weight management, I would say somewhat okay. Cost? Yes. He is a daily wage laborer, so I should always look into the cost. Then hypoglycemia, he is a daily wage laborer, middle aged. I don't think the patient has risk of hypoglycemia. So now my main aim is to treat the patient taking cost into consideration. What are the cheapest drugs we can use? I can use metformin. Then glimepiride. Then I can use pioglitazone, thiazolidine diones. Okay. Then if it's not getting control, I can use insulin, like mainly regular and NPH insulin, because they are cheap. Okay. And SGLT2, no. They are slightly costly. I don't think this patient will be. So I will start with metformin. The fasting blood sugar is 200. If the FBS is 200, the patient is likely to need 2 medications. If I cannot control with metformin and glimepiride, I might add this. If I'm not able to control even with this, I might add this or max to max SGLT2 inhibitors if the patient can afford for it. Like that only dapagliflozin. None other can Dapagliflozin. Okay, let's see the second case. A 55-year-old patient has HbA1c levels of 8%. She is hypertensive for the past 10 years. There are no other comorbidities. Her BMI is 28 kg. Her husband is auto driver. What are the things you should look into? Is she diabetic? Yes. Any HbA1c level more than or equal to 6.5 is considered as diabetes. So she is definitely diabetic. She is hypertensive for the past 10 years. There are no other comorbidities. BMI is slightly high, which is 28 kg per meter square. Her husband is auto driver. Now, do you want to reduce the risk of ASCVD in this patient? Yes. This patient has risk factors. She is obese, she is hypertensive, so you will have to reduce the risk of ASCVD. Do you want to reduce the risk of DKD? No. What about heart failure? Yes, the patient is hypertensive for the past 10 years. There are high chances that she might have systolic or diastolic failure. Weight management, yes. Cost, yes. Hypoglycemia, no. A young patient, chances of having hypoglycemia is very less. Now, what all can you use? You can use, I'll start from the cheaper ones, metformin. Then, in order to balance the cost, if metformin alone is not able to control her sugar levels, I will add low dose of glimepiride, that is sulfonylurea. Low dose glimepiride, 1 to 2 milligram per day. Not more than this. One of the important side effects of sulfonylurea is weight gain. Therefore, but at the same time, her husband is an auto driver and you should balance the cost. That is why I will add low dose of glimepiride, not more than 2 milligram per day. Pioglitazone, can you add? What is your opinion? It's a big no. Why? One of the major instances where you shouldn't use pioglitazone is where there is edematous condition or when there is heart failure. This patient might have heart failure. That is why I would avoid pioglitazone in this patient. SGLT2 inhibitor, definitely yes, but I can only use dapagliflozin, not cana or empagliflozin. Okay. So I will be able to manage her heart failure but not ASCVD because it's not affordable. In this, dapagliflozin. Then weight management is there. Yes, that is why like SGLT2 will serve the cause and cost. You can use metformin, low dose glimepiride and dapagliflozin in this patient to control the sugar levels. A 40-year-old IT employee is found to have diabetes. His BMI is 40 kg per meter square. Like he is very obese. Urine albumin creat is 40 milligram per gram of creat. Okay, so this patient is obese and this patient has protein, like the albumin ACR ratio is slightly on the higher side. So let's start. What all you want to do? Do you want to reduce the risk? Definitely yes. Do you want to reduce the risk of progression to DKD? Yes. Do you want to reduce heart failure? No, the patient doesn't have any comorbidities. Weight management is a big yes. Cause the patient is IT employee. I assume that the patient can afford some good medications. Hypoglycemia, no. A young patient is less likely to have. Young patients have their food properly, so they are less likely to develop hypoglycemia. Now, only thing that I can remember here is you can give metformin, okay? Can you give glimepiride? No. Why? Because one of the major side effect is weight gain. You cannot give glimepiride. Can you give pioglitazone? No. Pioglitazone also causes weight gain. Don't give pioglitazone. Can you give SGLT2 inhibitor? Yes. Okay. But when it comes to efficacy, GLP-1 receptor agonists are very good in weight loss. So for my first priority will be to start the patient on GLP-1 receptor agonists. There are two, semaglutide and dulaglutide. These can be given as once weekly doses. So I would like to start this. My first priority in this patient would be GLP-1 receptor agonist. Only if the patient is not able to afford this medication, only then I would shift for metformin, SGLT2 inhibitor, or gliptins. Gliptins are weight neutral. It won't cause. Metformin causes modest weight loss. SGLT2 inhibitor causes weight loss. It is also protective in diabetic kidney disease. Then gliptins. If patient cannot afford GLP-1 receptor agonist, metformin, SGLT2 inhibitors, only then I would go for gliptins. Is this clear? A 75-year-old pensioner is diabetic. He is also hypertensive for the past 20 years. BMI is 18. The patient is elderly. The patient is not like underweight. No, I would not say underweight, like slightly on the lower side. Okay. Now what all you should do? Do you want to reduce the risk of ASCVD? Okay. To some extent, I would say yes. DKD, no, there are no other comorbidities. Heart failure, yes, the patient is hypertensive for the past 20 years. You should try in reducing the risk of heart failure. Weight management, no. Cost, yes. Hypoglycemia, a big yes. The patient is elderly, so you should ensure that the patient does not go into hypoglycemia. Now, what all medications you can use? Can you use metformin? Yes, you can use metformin. Why? Metformin doesn't cause hypoglycemia. Can you use glimepiride? Glimepiride causes hypoglycemia. So, I would say maybe low dose of glimepiride. Start glimepiride from low dose, maybe 1 milligram per day. If the patient is able to tolerate and if the sugar levels are not getting controlled, you can try increasing the dose. But don't start with higher dose of glimepiride at the start. Why? Because glimepiride has higher chances of hypoglycemia. Okay. Pioglitazone? Yes, you can use pioglitazone. That's not a problem. Sorry, pioglitazone cannot be used in this patient because the patient is hypertensive and there are chances that the patient might have systolic or diastolic failure. You don't use pioglitazone or thiazolidinediones in the heart failure or the endometriosis conditions. SGLT2 inhibitor, yes, you can use it. Then insulin, you should use very, very carefully. Start with metformin, low dose glimepiride or SGLT2 inhibitor or gliptins. Gliptins also do not cause hypoglycemia. Okay, if you are not able to control with this, then maybe you can start insulin. Whenever you are starting insulin, you should be very careful that you start with the lowest dose possible so that the patient does not go into hypoglycemia. So these are the cases. From the next video, we'll actually understand, we'll go in depth about each class of medications. That's it.